Well, welcome everybody.
Good morning, Joanne, or good afternoon, I guess, or nearly noon. Yeah, the time zone thing is just a challenge.
Yes, indeed.
Including for our first speaker. Good morning, everyone, or good afternoon, good evening. I'm Guy Palmer. I am chair of this committee, and I just have a few comments to read before we get started regarding the process of this meeting and actually the activities of the committee relative to our task. As chair of the study and of this committee meeting, I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Science, Engineering, and Medicine is to examine the long-term medical and economic impacts of increasing antimicrobial resistance in the United States, and also the global impacts and influences. The task being undertaken by this committee includes commenting on the progress against the national strategy of combating antimicrobial resistance. The full task is described on the study website. I want to note that this is an open on the record session. Interested individuals, members of the press have been invited to attend as observers. However, this is not a news conference and we will not be entertaining questions from the floor. Reporters who would like to speak with committee members are asked to touch base with Jillian Buckley, who is the study director, and her contact information is available on the study website. I want to remind everyone this is an information gathering session. The committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask that everyone here be mindful of the fact that the committee has made no conclusions, and it would be a mistake for anyone to leave here thinking otherwise. Comments made by individuals, including committee members, should not be interpreted as positions of the committee or of the National Academies. Committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal professional views. The committee will deliberate thoroughly before writing its draft report. Once the draft report is written, it goes through a rigorous review by experts who are anonymous to the committee, and the committee must then respond to that review with appropriate revisions that adequately satisfy the National Academy's Report Review Committee and the National Academy of Sciences president before it is considered an official National Academy's report. So with that, I would like to proceed with our program for today and introduce our first guest and speaker, Dr. Claire Chandler, professor in medical anthropology and director London School of Hygiene and Tropical Medicine, who's going to speak to us about the anthropology of antimicrobial resistance. So I'm going to turn it over to Claire and we'll get started.
Can you see my screen but not my notes?
Yes, exactly. Okay. Perfect.
Thank you very much for the invitation to talk today. So I'm the director of the Antimicrobial Resistance Centre at the London School of Hygiene and Tropical Medicine and a professor in medical anthropology. And a lot of my research in recent years has centred around medicines and in particular antibiotics. And prior to that, I did quite a lot of work on malaria, including on the use of antimalarials and reduction of antimicrobial use through diagnostics. Today, I'm just going to talk for 20 minutes because I was told to allow 10 minutes time for questions. So I thought I would just go through, first of all, something you all already know, the problem of antibiotic use. I will just outline in a couple of slides because I think everybody's already familiar. And then I'm going to talk through some of the more recent sort of focus of stewardship interventions and discuss a little bit about where some of the challenges lie, particularly from the perspective of anthropological studies that we have been doing. And then think a little bit about framing ways forward for stewardship, as I think that's one of the focuses for this, this group at this point. So the problem of antibiotic use, this will be a familiar figure from Klein et al. So this is actually consumption data for humans, but it's a similar picture in terms of seeing increasing use when you use other kinds of data, for example, patient household survey data, or from health facilities, in terms of the trajectory of a rise in antibiotic use. So we know antibiotics are being used quite a lot, and that's despite a lot of efforts to try and reduce our reliance on antimicrobials. And one of the points that I think is really important when we're thinking about wanting to address this in order to reduce the threat of antimicrobial resistance is that antibiotics are used in a lot of different areas of life. So we do use them in formal healthcare settings, and that may be inside of hospitals all the way through to home care, but under a formal prescriber. But also there's a lot of antibiotic uses used outside of these settings, particularly in over-the-counter sales and self-care. And also obviously being used in the agricultural sector, including from all the way through from small to large scale farming. And I've got a picture here of a chicken, but also in other livestock, as well as in pets, and also in crops. So we've been studying, for example, in one of our research studies in Thailand, the use of antibiotics drilled into trees to reduce the effects of citrus greening disease. So antibiotics are being used in increasing numbers rather than decreasing, and we see that particularly in low middle income country settings that increase. And I want to argue here that in terms of a problem statement, antibiotics have become infrastructural. What I mean by that is that we have become very entangled with them in our everyday lives. They've become part of what we take for granted across all of those settings I've just mentioned. And I think what's been very useful is this rise in concern about antimicrobial resistance allows us to see quite how widespread and how deeply we rely on these medicines across lots of different settings. So we might see antimicrobial resistance as a moment of inversion that allows us to see what we've been taking for granted for so long. And just, I'm not going to do lots of social theory, don't worry, but just as an opener, this idea that antibiotics are infrastructural comes from these ideas of infrastructures as good usable systems that disappear almost by definition. The easier they are to use, the harder they are to see. And of course, during COVID, we've seen a lot of our infrastructure becoming a lot more visible. Things like people, coming to collect our rubbish and so on that we don't usually see. It suddenly becomes visible when it's absent. And the threat to antibiotics, and indeed the failure of antibiotics, makes us a lot more aware and tuned into the wide range of places that we are using them that we perhaps hadn't realized. But the other part of it being infrastructural is that it's connected to ways of life. It's connected and entangled with our current ways of living. Our political systems, our economic systems, our social systems currently are entangled with these medicines. So if infrastructure defines what's possible, then this inversion of infrastructure that we see with antimicrobial resistance allows those possibilities to be reopened. So if antibiotics have become infrastructural, and we see that because of this moment of inversion of AMR, we can then start to think about other ways of organizing our infrastructures that can design out antibiotics. So that's my initial couple of slides on the problem of antibiotic use. There are lots of different definitions of stewardship, and I'm just going to focus on a couple of the most current sort of focuses that people have for how we do stewardship. But I would just note that historically, stewardship had perhaps a broader remit than we tend to see today. Even though seems to have started more in hospitals, particularly in the US and in Australia, the idea of stewardship being a system within the hospital that is related to laboratory systems, dispensing systems, and so on. More recently, we see this perhaps a shift towards making this a behavioral problem, that it is embodied within people. It's within people to change their practices. So we see much more attention now on the idea of awareness, so that people should be aware of the risks of using antibiotics, and that AMR is rising, and therefore they need to change their behaviour. Also a rise in the idea that we should use educational programs to tell people how they should use antibiotics. And often we see this idea of champions either emerging by themselves or being harnessed as people through whom we can attempt to change stewardship and to improve behaviour through individuals championing new ideas. And often we see these ideas of pledging and being a guardian, and I'll talk a bit more about that. Also, technologies tend to be part of this. So, as tools with which one might argue we are trying to communicate the same message, that we need to be changing our antibiotic use patterns. We use various different kinds of technologies, including diagnostic testing, to try and underscore this change in behaviour. So far, the evidence based on how best to achieve stewardship is quite mixed, however, particularly across different settings. And in many settings, we still really don't know how best to address the rise in antibiotic use. And a lot of the stewardship interventions that are loosely under this umbrella of stewardship are not having a significant enough effect to actually change that direction of antibiotic use. So social sciences have been called upon to address these behavioural problems. And yet there is still very little social science. It's just a slide just to show you that the social sciences are in that one of less than 1% of all of the AMR research. In the London School, we have quite a large research group studying the anthropology of AMR, and this is some of our ongoing research projects listed on this map. Anthropological research places an emphasis on immersive observation, on trying to trace out stories, not just listening to interviews, but trying to interpret those in the wider context. So we spend quite a lot of our time looking at archival material, looking at media, analysing policy documents, how programmes are operating. But we also do quantitative work. We do surveys with residents, for example. We've been doing these drug bag surveys to look at how much antibiotics and which types of antibiotics people use. Do health facility surveys, done a prescriber survey, which I'll talk about in a moment. And we also get involved with interventions. I'm going to just give some results of a survey that we did about awareness. So awareness is the first area that I want to focus on. We did a study with healthcare workers, humans and animals, animal healthcare workers across different settings funded by the World Health Organization. And the objective of this was actually to create a measurement tool to assess awareness. Just to give an idea of actually how aware were these prescribers of antimicrobial resistance, really quite aware. So the tool measured awareness of mechanisms of antibiotic resistance, the ways that antibiotic use drives resistance, the ways that resistant infections can be transmitted and controlled, and how antibiotic resistance can be recognized, so through different kinds of diagnostics and so on. And actually we found a much higher level of awareness than we were expecting, although you'll see these error bars are quite wide. And we also found that with the animal healthcare practitioners. We did quite a lot of qualitative research alongside this, which did emphasize also that healthcare practitioners who were prescribing antibiotics were really quite aware of the problem of antimicrobial resistance. And indeed, one of the challenges that we discovered was, or a challenge for us as public health, with public health in mind, was that health workers were aware of AMR, and that would actually at times increase the impetus to prescribe the next line treatment. That actually being aware of antimicrobial resistance doesn't necessarily equate to reduced prescribing, but may equate to the use of a next line treatment more readily. And the role of drug reps was really important, we found in this study. And so you can see in this is from one of our study sites in India, you can see that this wall art that was given to the practitioner is advertising that this particular antibiotic has a proven efficacy. So the idea that healthcare workers really do know that one drug might be better than another, and that antimicrobial resistance is one of the reasons that some drugs don't work. So what we find is that awareness is already reasonably high. So raising further awareness may not be what we need more of here. And in fact, the knowledge that people have about antibiotic resistance and the potential for their current prescribing practices to impact resistance is outweighed by their need to cover the patient. So to ensure that the patient is not going to be at risk because they're not giving them an antibiotic. One of the other issues with the awareness raising programs is the way that they can have unintended consequences. I was just mentioning that they may actually increase the likelihood of using next line antimicrobials, but there's also the unintended consequences of the ways that metaphors are being used. And I think we're all becoming a lot more tuned into this with COVID as well, that notably the war metaphor, which characterizes an enemy, that this is easily politicized, and it has both meta-level consequences, for example, the interchangeable anxieties of superbugs and immigration, but it also cultivates a public culture of danger, which is perhaps understood to translate into public pressure on politicians to act, but that model that by raising public awareness, you will then be able to influence politicians to act, does not necessarily equate in every country around the world. That state public relations are actually quite different. So, and yet we transport our awareness campaigns around the world. And similarly, the idea of antibiotics being used by like sweets is one that we've seen being used around the world and exported to different settings, where really the major issue is access to antibiotics. And it's a very strange feeling to see these kinds of adverts telling people not to use antibiotics like sweets in settings where for the last decade or more, it's been incredibly difficult to even get access to the first line antibiotics. And there's a reasonably high death rate from the lack of antibiotics. So the ways that we've been trying to raise awareness have been quite blunt instruments that have had other consequences. And our anthropological research is kind of with that sort of depth and the kind of rich description is able to pick up on some of those things, as well as quantitative research. Education is another area, and I think it's important to distinguish different components of education. There's education that happens within curricula, which needs to be built, and there's information which might go along with antibiotics, which also is needed. But what we see mostly is this, what I would call a top-up to prescriber knowledge. And here we are talking about asking people to change their practice by giving them some additional information or additional training to tell them what they should be doing, or through a change in guidelines. But often what we find in reality is that the guidelines are conflicting with the roles of these prescribers within a system that makes these drugs necessary in their view. And so our analysis here has really brought us to this idea that antibiotics are being used in many situations in place of other things, so that they actually provide a quick fix for care, that they provide a quick fix for hygiene in scenarios where either the knowledge of home situations means that we know they're going to go home, and then if they're not, don't have a bacterial infection now, they will by the time they get home. So I'll cover them with an antibiotic, or within health facilities, knowing that the infection rates within health facilities are high, the idea of covering your patients to ensure that they aren't at risk of severe bacterial infection is really common. So there, the antibiotics are serving as this quick fix. And then also a quick fix for productivity and inequality, which we wrote about in this very short article, and used this graphic to try and communicate the way that the antibiotics are sort of propping up systems in many settings. So here, the idea that if we're going to be using education, it's kind of these top-ups of education sort of provide a veneer which can do as much harm as they can do good, or often make minimal difference in people's everyday practice. So the question there being, can we really educate people out of a scenario that is more systemic? And then the third area that I wanted to cover was the tendency to use champions. And here, thinking about wanting to scale up stewardship through champions. So we want to have a stewardship system, and we recognize the need for that to be systemic, but actually we end up translating that into individuals who are expected to go and take that on board. And the idea that they are going to be stewarding these medicines. And so on the one hand, this has an issue with the burnout that we see with champions. And also it's obviously reliant on individuals putting themselves forward. But even when we do see people taking that on and pledging to be guardians and stewards, we have to be cautious about what we're asking them to do. And one of the things that we've been looking at is the way that whereas our stewardship should be a means to an end, in terms of the end being we want to improve the health and care of individuals both now and in the future through ensuring we have drug availability. What we actually see then is the guarding of the medicines becoming the end in themselves. And that's what we've got to be really, really careful of with stewardship programs, is to ensure that they are situated within a wider context of ensuring that people are getting good quality care, and that this is part of a wider package of ensuring care. And we can really see this in low middle income country settings, where we see a shift from what used to be called the rational drug use programs internationally. And we now see an increasing use of the word stewardship. And that actually that has shifted from the idea of guarding patients and the public purse through rational drug use to the idea of guarding medicines themselves. So what might be some ways forward for stewardship? I've got two slides here. The first one is to think about how we can design out interventions, design out antibiotics, so that we're not just thinking about asking individuals to champion this and to do this by themselves, that actually a lot of the stewarding of antibiotics can happen outside of individuals and can actually happen within the systems that we design. And we can change the care systems, the sick leave systems, economic systems, and causes of inequality that will then mean that we are less likely to have to rely on antibiotics to perform these functions for us. But these are quite big, these are medium to long-term strategies that might achieve that. Perhaps in the shorter term, we might start to see, instead of having individuals taking on the stewardship role as the core, that actually we might want to shift our focus towards seeing systems as stewards and actually tweaking the ways that we use what are often mundane and overlooked artifacts, points of connection and disconnection, including forms, algorithms, supply chains, that these can become focus for intervention to steward these medicines, rather than necessarily expecting it all to be embodied within the behaviour of individuals, as we tend to do through the predominance of awareness, education, and champion type programmes. And I would just like to end with some acknowledgements to my many colleagues who have been working with the anthropology of AMR teams in different countries around the world, and to say that there is a website for social science in antimicrobial resistance, which has people, and it has a list of different people who are working in this area. It has a list of resources and essential readings and some commentaries, and that's the website there. Thank you very much.
All right, thank you, Claire. That was really marvelous. Hopefully, I have some really good questions. Kevin Outerson got in very quickly with his question, and he's learned the system. What would you say to funding agencies about the role of social sciences in our societal response to drug-resistant infections?
Well, more of it, Kevin.
Yeah.
I mean, we need to be funding more of it, but we also need to be more strategic about the kinds of things we're funding. And we need to not keep funding the same thing and finding the same thing. Systematic reviews have an important role to play in this. And there have been dozens of systematic reviews of stewardship interventions. So I think we're done with doing the same thing, and we need to do something different. We really need to be building that evidence base that is doing more difficult things. We need to be building the evidence base that is using different kinds of evaluations as well, so that we can detect those unintended consequences. So I think we do need more of it, but we need to be careful about how we, what kinds of social science we're encouraging and commissioning.
I'm going to have Andy Strigachis ask a question in a minute, but I'm going to sneak one in first. So I noticed you had also done work not only in wealthy countries, but also in LMICs. And how does it differ, the societal perception of this as a problem? Is this considered to be, this is a first world problem, if you will, and versus in LMICs, it's not viewed, resistance itself is not viewed as a huge problem. It's more viewed as access, and maybe that efforts to what we might call stewardship can be viewed as restricting access.
Yeah, I mean, I think it depends who you're talking to within a country or within the LMICs. But if I were to take, if in any country, you're going to have a very different viewpoint from the people who are running the AMR coordinating committee to your patients in a rural area who are struggling for access to antibiotics. Across the board, people are aware of the concept of resistance. They're aware of the concept of fake drugs, and they're aware of the concept of resistance. So those are the reasons drugs sometimes don't work. They're aware that antibiotics are different, whether they come from, the provenance of those drugs is a big thing, whether they're coming from Europe or other countries, it tends to be a big thing about the efficacy that's understood that those drugs will have, particularly in the African settings that I work in, although I would say that is not universal in, for example, in Myanmar and in Thailand, there are studies showing that community members don't necessarily know what the drugs are. The difference between one drug and another drug is not, is something that's kind of hidden from view from the person that's taking it. So they don't necessarily know it's even an antibiotic. Whereas people are quite conversant in that, in the African studies, that study sites that I work in. So people are aware that efficacy of drugs matters. They're aware that there is this idea that if you overuse them, then there will be a problem, and the provenance of them. So that those things kind of get muddled or get mixed up together or conflated about efficacy. So I think people are really concerned about efficacy across the board. Whether in terms of the prioritization, is this a first world problem? I think people are concerned about it right now because the majority of people who are dying of drug-resistant infections are people like mothers who are going into maternity wards and not coming back out again. That's happening right now in LMICs. So people are aware that drug resistance is a real thing that's really happening to them right now. And that's about a lack of access to the next line treatment. Those treatments are available, they're just not available to them there.
Right. Thank you. Andy, go ahead with your question.
Yeah, a lot of questions, but I'll limit myself. Thank you. What does social science tell us about how to motivate and better mobilize political will to address AMR?
Yeah, there has been quite a bit of research that's been done by various groups about the ways to get AMR more on the agenda. I would say the research that I've been doing is slightly kind of cautious about the consequences of some of the ways that we do that. So whereas I think it's clear that you can make people very afraid and therefore want to do something about something because they're afraid. There is at the same time this concern that we've got people very afraid about AMR. They want to do something, but then there's what's been coined as the implementation gap. And I think that there's a really important role for social science there in understanding what you do once you've got people all galvanized at one level, and then how that actually translates down. And I think the mistake we may be making a bit at the moment is to imagine we should use the same model of trying to get people all worried at every single level of the system. And when people don't have the agency to be able to do anything about it, being worried just is a negative spiral. And there isn't always recourse to be campaigning to your MP. That is not a system that translates around the world everywhere. So I think that the path to getting politicians concerned about things is pretty well trodden. The getting something translated into implementation is a slightly different problem, requires a different toolkit. And I think that's where some of the analysis that social scientists do can be really valuable in terms of not only the levers for change and the levers, and a lot of our colleagues who work in international relations and in law are pretty good at that kind of side of the levers, but then also what are the consequences if you do go down some of the other tracks that social scientists are quite good at. I don't know if that answers your question.
It starts. Thank you. Thank you.
Okay, I'm not seeing any other hands up at the moment. So I do have one more question. Claire, which is the difference between kind of knowledge and what should be done and then the individual action that individuals take. Because Andy's from Seattle, always, I'll tease him that people in Seattle are very, very much for mass public transportation so their neighbor can use it. So a little bit with antimicrobials, does that same thing that occur that everyone on a societal basis, yes, this should be done. On a personal basis, it doesn't change what happens at that moment, either from the individual when they have direct access to antibiotics or in a prescribing situation, as you've mentioned, the idea of, covering / protecting their patient.
Yeah, I mean, and I don't know that it's necessarily that that's the same piece of information. So the knowing that information in the abstract, that there is this thing called AMR that's happening, yes, as a, on the meta level as a process, is one thing. Dealing with my patient in front of me, who certainly looks like, if they've not got sepsis now, they've got a good chance of getting it. And I've had enough cases of that to know that I'm not going to make that mistake. That's not, those two things are two different worlds of information. And the idea that if we just strengthen the information about AMR, that's going to mean that people will then be thinking that when they've got a patient in front of them. Actually, the kinds of information they need about the patient in front of them are quite different. And that's where we've seen some successes with sort of more experimental, knowing that, only, X% of these cases, when they come in, only X% will go on to have these problems. And then knowing that you can do a delayed prescription. So having these techniques, like you can go away with this prescription, but don't fill it unless you feel worse, or you can come back. So this is what we would call safety netting interventions. Those interventions allow the clinician to have a safety net, and they allow the patient to have a safety net. You go away with your piece of paper, or you go away knowing that you can come back, and everybody kind of knows that if this gets worse, we'll be able to deal with it. And that's what the drug at the moment is often doing in other settings. Where you don't have recourse to a safety net, that's where the antibiotic continues to be the insurance itself. So, and that's a very different thing to knowing things about AMR.
Yeah, good, thank you. Just very quickly, we're about to switch over to Chris, but there is one more question from Erica, which is, what would it take to interest more social scientists in AMR?
It's a great question. I mean, I think that a lot of social scientists are interested in it. I think what they find frustrating is that the types of questions we're being told that we need to answer aren't typically the types of questions that get you, that we feel like, well, we've already answered those questions, we're being asked them again. So I think having a broader scope and a broader remit for social science and AMR would be really valuable.
All right. Thank you very much, Claire. Really appreciate it. We're going to now proceed to Chris Murray, who's the director of IHME, the Institute for Health Metrics and Evaluation at the University of Washington in Seattle. It's going to speak about the global burden of antimicrobial resistance.
Thanks, Guy. And let me share screen. Let's see if get this to work. Okay. I am going to talk about the global burden of AMR. And are you still there, actually, Guy? Can you hear me?
Yeah, I can hear you. Yep, and I can see your slides.
Okay, Zoom was sending me crash notes. Global burden of AMR, I'm going to run through all these topics pretty quickly. This is a large undertaking with many people involved, and I'm just going to try to give a flavor of what we're trying to achieve. So first context is, this is an effort started by Sally Davies, and it is fundamentally the idea of bringing into the annual global burden of disease assessment quantification of AMR. And so for those of you not familiar with the global burden of disease, it's an annual undertaking. It produces country level estimates for a comprehensive set of diseases, a not comprehensive but extensive list of risk factors. It's a time series analysis at the country level and is at the subnational level in 22 countries. And all the data and code that goes into the GBD is in the public domain. So also critical to understanding the context of the burden of AMR and bringing it into the GBD is the GBD is now a large scale collaborative effort with 5,600 collaborators. And has its own quite complex study governance structure with multiple tiers that are both from within the study investigators and external bodies such as the Independent Advisory Committee that oversees the effort. And of course, there's the normal process of peer review. Now, the AMR part is very excitingly a close collaboration between people at IHME and a unit at the Big Data Institute at the University of Oxford. And the funding for this effort has come from the UK Fleming Fund, the Wellcome Trust, and the Bill and Melinda Gates Foundation. Now, what are we trying to do in this study? We are trying to estimate the burden. And I think it's very important to start with a core philosophical question, which is, what is the counterfactual that we are trying to evaluate? Namely, if we observe a world today with a certain amount of drug-resistant pathogens, and there are two counterfactual questions you could ask. The first is, what would be the reduction in the burden of disease if all the pathogens that we observed were drug sensitive? Or what is the burden of disease if all the infections went away from drug-resistant pathogens? So the two counterfactuals are drug-sensitive infection versus no infection. And the first question is the one that's closer to what we normally do for a risk factor in the GBD, and that's certainly our first priority. But there's quite a bit of literature in the AMR world that's answering the second question, which is, there's arguments in favor of the second question, but not arguing that removing drug resistance would actually remove 100% of those infections. So probably that's very much an upper bound of possible burden you could attribute to drug resistance. And the first question is probably the lower bound of that range. The other objectives are to set us up so that we can, on an ongoing basis, on a yearly intake, incorporate AMR as a regular feature in the annual GBD. And then there's the use of this effort to identify data gaps, as well as to set the world up and analysts up to have a time series around AMR that would then allow much more rigorous forecasting models to be developed for the future. Okay. Analytic strategy. Well, it turns out, as you all know on this meeting, that there's huge data sparsity. There are many aspects to trying to think about drug resistance and its burden. And so we've tried to build a framework that allows us to leverage many of the data sources that already exist in the GBD framework, as well as to triangulate with as much data as possible that meets inclusion criteria for each component. And so here's the rough analytic approach, which is we start with deaths from underlying cause. So that's ICD underlying cause. We figure out the proportion of those deaths that were sepsis, and I'm talking about the more modern definition of sepsis, which is any major infection with end organ damage, not bloodstream infections. And then the proportion of those sepsis deaths by a particular clinical syndrome. Did the person die from a pneumonia or from meningitis or from a bloodstream infection? Then the fraction of that clinical syndrome due to a pathogen, and then the relative risk of death if you have a drug-resistant pathogen versus a drug-sensitive pathogen. And our goal in this project is to get all the data that we can find for each of these components and then pull it together. Now, of course, this is a very large scale set of combinatorics. When you start to think of underlying cause, clinical syndrome, all the different pathogens, all the different drugs, and we are able to find data on only some components, and then the estimation of the sort of residual is certainly going to have much more substantial uncertainty. Okay, first step, estimating the fraction of each underlying cause in the ICD framework that is due to sepsis. And for that, we've used the data that we can find from about 10 countries, 114 million deaths, where we have multiple cause of death data. And we can look in multiple cause of death data for directly coded sepsis or indirectly coded sepsis through a variety of codes or indications that there was a major infection involved in that death. And then we take this data and we model for the rest of the world, obviously a big step going from 10 countries to the rest of the world, but we develop models that predict this fraction dying from sepsis as a function of covariates, the most important covariate turning out to be the Healthcare Access and Quality Index. So this is just to highlight this, more recent definition of what sepsis means for the critical care community, and not what, for example, what I was trained on as an infectious disease physician, where it really was equated with a bloodstream infection. So using that broader definition and this modeling approach, we end up estimating that of the 54 million deaths in the world in 2015, 13 million were due to sepsis. And some of those sepsis deaths are from non-infectious underlying causes like ischemic heart disease or stroke, where somebody's in the hospital, perhaps for a prolonged period, and ends up dying from sepsis. And we published the results of this analysis back in January, a year ago, seems like an eternity, pre-COVID, with the results of the number of sepsis deaths from infections in orange here over time, from non-communicable diseases where sepsis is the modality of death, and then from injuries where sepsis is the modality of death. All right, so now we know, or we approximate with uncertainty, which is quite wide and depending on the data, the fraction of each cause of death, underlying cause, where the pathway to death goes through a major infection. So next is figuring out what clinical syndromes are actually involved. And this is important because that's the way we're going to get to pathogens, and that's the way we're going to get to bug-drug combinations and their impact. So for the fraction, we use a similar approach where we're using the same multiple cause of death database that I used just before, and we run regressions to try to figure out what is the fraction of each of those deaths due to sepsis by particular clinical syndrome. And I'm going to illustrate through the rest of this presentation how we do this for meningitis, and picking that as an example, given the detail that's involved in the various steps. And when we do that analysis and then predict out for other countries with covariates, we end up with this sort of view where the blue bar is number of deaths due to meningitis. That is where meningitis is the underlying cause of death in classic ICD terms. And then the orange is the other deaths where meningitis is a pathway for some other underlying cause. So it gives us a larger number for that clinical syndrome than just counting underlying cause due to meningitis. And certainly for things like pneumonia, bloodstream infections, you know, this difference is really quite large. Okay, then on to a little bit what may start to look a bit more familiar for people looking at AMR, which is understanding the distribution of pathogens for each clinical syndrome. Now, a lot of the work, and we're now into, you know, coming into the end of our 5-year project, a lot of the work has been trying to amass a database for each clinical syndrome for what are the pathogens involved and whether that pathogen is resistant. And that is a combination of trying to negotiate access to microbiological data sets from different groups, using existing microbiology surveillance systems, Atlas is an example, working with companies that provide microbiological equipment like Becton Dickinson, and negotiating access to that data, and then particular hospitals or sites around the world. And then that is supplemented with literature reviews. So for example, for meningitis, we're able to find, in addition to the microbiological data that we directly get, to the hospital discharge data we can get in many countries. We also have 56 published studies that tell us about the pathogen distribution for meningitis. And here's a rough summary. We have, you know, not an enormous, but a couple 100,000 specific cases where we know the pathogen for meningitis across these data sources. And then we supplement that with the published papers, and we get the map on the right of the distribution of where we have some data. So there are huge gaps around the world where we don't have data, but you know, compared to some outcomes in the GBD, this is not so bad. And of course, we will then depend on modeling to fill in the gaps to come up with a first order approximation of what is the distribution by pathogen by location. Now, there's an interesting challenge here, which is that much of the data that comes on pathogens from these published studies or from surveillance systems or from even, you know, quite comprehensive microbiology data sets don't cover a full spectrum of pathogens. So very often we'll find a study that says there's data on these 4 dominant pathogens, and here's the fraction of the meningitis, in this case, for those 4 pathogens, and they don't tell us about the distribution of everybody else, and they don't even report other. So we've had to adopt or modify existing methods, namely network meta-regression, and a particular approach of network meta-regression using a tool developed by the math sciences team at IHME called Mr. BERT, which is a meta-regression Bayesian regularized trimmed tool. Is publicly available if anyone's interested in using it. And we use that, the network component of that, to deal with the fact that a study may only tell us about, strep pneumo versus Haemophilus influenza, and not about the full spectrum of pathogens. Now, the beauty of using a network approach is we can use all the data that's out there, we can use covariates, and we can figure out what is, how all the data fits together in a comprehensive way. And there's one further step. Some of the data sources we get tell us about incident cases. Some of the data sources tell us about only those who have died. And so we also need to map between those 2 different types of data. And the way we do that is we do systematic reviews and meta-regression to figure out the case fatality rate for different pathogens. And then we're able to use both types of data, and we're able to analyze the pathogen distribution for incident meningitis in this case, or pneumonia, or whichever component, as well as for death. And here's the results for meningitis, split by age group, under 5 to 65, 65 plus. We don't think the data support more detailed age splits. And it also shows by what in the GBD parlance are called super regions. The GBD has a hierarchical structure where we evaluate things produce results at the country level, but we have regions, and then we have large groupings of regions, these 7 super regions. So this is just showing you the results for the super regions, and it shows the distribution of pathogens for cases at the top and deaths at the bottom. So very interesting, set of results. I think we have been talking to many groups about does this trigger issues around the face validity of findings, and that's helped us stimulate others to contribute more data to the effort. But this is what we have now produced, or are producing actually, or finalizing as we right now, for all the major clinical syndromes. Okay, then we go to prevalence of drug resistance. This is a little bit more straightforward in the sense, not that there isn't huge data issues and issues around potential bias from different types of data sources that we need to deal with, but we don't have that problem, for example, of what is the universe of being compared when we look at distribution by pathogen. So for 17 bug-drug combinations, which are the WHO priority drug-bug combinations, the team at Oxford has done full systematic reviews. And then for 66 other drug-bug combinations based on all the pathogens for clinical syndromes that are more than, we want to account for at least 90% of the pathogens in each clinical syndrome. We have used the data sources from the microbiology networks and surveillance systems that we have access to, but have not been able to conduct full systematic reviews. And then for each of these, we use a quite complex modeling strategy to deal with missing data, where we develop a model ensemble. And then we put that model ensemble, looking for different predictors and different relationships between predictors, into a spatial temporal Gaussian process regression framework. That combination in out-of-sample predictive validity testing performs the best. And just for those interested in what goes into the ensemble, there are some generalized additive models, some penalized regression models, and some neural networks. And those go into that ensemble, and then we put that in this spatial temporal framework. Here's an example. This is the data on Klebsiella and 3rd generation Cephalosporins. And you can see the data. These are by regions. The models are actually fit at the country level. And then you can see the regional prediction with uncertainty by location. So, the models the data is very noisy, as I'm sure you're aware, but these models do a reasonable job of picking up if there is a coherent trend in the data. Okay, so now we've done that for pretty much every drug-bug combination that meets a certain magnitude of potential burden. The last part of this analysis is to figure out relative risk. We look for published studies, and we also use linked data like the Becton-Dickinson microbiology data set, where we know outcome as well as microbiology. And we both estimate directly the relative risk for resistance as well as take the published results. And then we use meta-regression to generate results for relative risk. Where there's plenty of studies, this is straightforward. Where there's not, we've had to devolve to less sophisticated methods where, for example, for a particular outcome, we use a simple fixed effect by pathogen. And we take advantage of the Bayesian framework that we use for meta-regression to avoid being overly sensitive to single studies. One study that's small, that gives a huge relative risk. We want to protect ourselves from extreme values from data sparsity. And here's an example of the relative risks we get for drug resistance, E. coli with, here's 3 examples, Klebs, and then Staph aureus, Staph pneumo, and Haemophilus, just as an example of what you get with this meta-regression approach on these published studies and the linked studies that we have access to. So then we put all that together. That's the part that's not yet complete, but in the GBD framework, we take the uncertainty from each of those steps and we use simulations or sampling to propagate the uncertainty from each component into the uncertainty that we have for the final results. And that uncertainty is a sort of helpful guide for where better data is going to narrow uncertainty in the future. So what's coming next? We are planning with the funders to target release of a first set of burden of AMR numbers for May. We know, because of the really hard work done by the team at Oxford and by Andy Sturgakis and others, that a number of new data sets are coming in the coming weeks. So we're hoping very much to get those built into the estimation. We recognize that in producing these very first round set of global burden of AMR estimates, there's a lot of learning, and we expect to iterate in coming cycles of the GBD and take on board the various sort of insights that people will get from looking at a set of results from around the world. We also believe, and getting some feedback, that the distribution by pathogen, that sort of standardized systematic approach that we've implemented, is a useful byproduct of this work on its own right, because it's been difficult, as I'm sure some of you may know, in coming up with location and age-specific pathogen estimation, given the sort of complexity of the data that's in the literature. So I'll stop there. Thank you.
Yeah, thank you, Chris. Got a couple questions. I think we have a little bit of time left, Eris. You've got a question. Let's start with you.
Thank you both, Chris and Claire, for the presentations. That was very useful. A question that I have, Chris, is two questions that have to do with the margins of your work. The first, actually I have 3 questions now. The first question is sepsis. It's not only a result of resistance or the pathogens, also a result of the immune response. How do you stratify the need for better antimicrobial agents versus the need of immunomodulators that will dampen down the immune response? The second question that I have is resistance is a factor that is somewhat arbitrary based on in vitro evaluation of a pathogen. And in the case of meningitis, something, a pathogen can be susceptible in vitro, but still, because the pathogen is in the CNS, be resistant in practice. How do you account for that? And one clarification for your data, you said that the data do not support further stratification based on age. Did I understand it correctly? You think that you have the data and you don't think that they they need to be stratified any further, or just you don't have the data available to you to stratify further? Thank you, and I appreciate it.
Great. Guys, should I answer those?
Sure, yes.
Okay. On the immune response, very good question. I think the critical care definition there is sort of end organ damage and major infection. Arguably, it's hard to die from an infection and not meet that criteria, right? So, but I certainly agree that there are other aspects of reducing mortality that are not related to the pathogen per se, but to modulating the immune response. On the second question on resistance in vivo, in vitro, so, because we get the relative risk as part of this, we are able, I think, to reasonably accurately answer the question, how much worse is the outcome if you have an in vitro resistant pathogen? That does not answer the question, as you have pointed out, that, are you going to reduce, because the case fatality rate for drug sensitive is still quite high, particularly in low resource settings. And that's also built in essentially in the GBD framework, where we see deaths from meningitis, we're estimating that. And so it's really getting that incremental effect of resistance that I think this is reasonably unbiased. On age, I think I spoke too quickly there. The GBD is always by 5-year age group. So the results are by age group. The one part where we don't think the data is just too sparse right now is to get the pathogen distribution different by 5-year age group. We tried, but the models just don't really support that. So that's where we've gone to this much more coarse framework. But all the other components are the usual full specificity in the GBD by age group.
Okay, there's another couple quick questions, one in the chat about does the AMR data, where some labs use CLSI standard breakpoints, others use UCAST, and probably others use a variety of things. How does that figure into your analysis, or is it, basically how does it?
Yeah, no, it's a great question. And I think there's just a lot of detail to try to deal with. And I mentioned on the prevalence of resistance, a variety of bias covariates that we try to stick into those meta-regressions, which include some aspects of labs, aspects of MICs, and other criteria that are used. That effort of post hoc standardization within the meta-regression framework is obviously imperfect, but there is some attempt to get at comparability by using, covariates in the meta-regression framework.
Yeah. One comment by Mary, she was asking Mary Wilson, whether your report was going to come out in May of 2021.
Oh,
I think your slide said May 2020, and we got to leave that year. We got to leave that year behind, Chris.
2021. Sorry.
All right. One other question I had is, can you now take this data and overlay interventions on top of it, and just take something like pneumococcal vaccination? Can you see effects of interventions? I know you're layering multiple things on top of one, and it can get complicated that way, but on the other hand, this is what you do. So
yeah, I mean, we already include in, for example, the pathogen models, we include vaccination as a covariate depending on the pathogen. Right? So the model's already trying to find that relationship. Again, it's part of this general issue about trying to bring in both, expert knowledge as well as what's in the data into a set of, reasonably coherent results where we have gravitated to these Bayesian tools where you can, for example, say, we really do believe that vaccination works, and therefore we expect a reasonably strong relationship between the fraction of whatever the outcome, let's say pneumonia, that's strep pneumo, there should be a relationship, and a negative one, with vaccination rates. And so we do tend to find that, but we also just try to make sure that those sort of common sense relationships are present in the structure. So having included that in the estimation, I don't think this is the right setup to be evaluating that, because it becomes a tad circular.
Yes, got it. Just got one more question here. We've got time for one more. Any observations on the data quality for AMR as compared to your experience with global burden of disease for other major categories? Just kind of a data quality argument question.
AMR is quite challenging, right? So I'd say it's more challenging than many outcomes, partly because of the complexity, because of all the nuance about how different labs function, how drug resistance is measured, the huge lack of linked data, because most of the data on bugs come from labs, and very few data sets link it to either the patient syndrome at presentation or to the outcome. So the number of data sets where we can actually trace through to outcome is extraordinarily limited. And that's a huge gap just because of the nature of where most of the microbiology data comes from. They're not linking it. So that's a big gap. It's a bigger gap than we see in many other outcomes. Think TB, where, because of cohort registration of cases, we have an enormous amount of linked data just coming in every year from sites around the world. This does not exist here on the AMR front. So it is probably a bigger challenge. And of course, it's a bigger challenge because you need to get into the detail of drug and bug. So that matrix is a big matrix, right? Yeah. So it adds to the detail that we need to understand. Yeah.
Okay. Super. Chris, thanks very much. Claire, if you're still on, thank you very much as well. I'll let you get on with other activities of the day. The committee is going to take a break, and we're going to reconvene at 20 after, no matter what time zone you're in. So, all right. Chris, thanks again. Claire, thank you very much.
Thank you, Chris.
Thank you. Bye-bye.